All right, everyone. So we have Dr. Thomas O'Connor here, the metabolic doc. He's an expert in testosterone replacement therapy and treating men specifically. Now, do you work with women as well, or is it almost entirely men?
No, only exclusively men.
Exclusively men. Okay. And you're an expert in a lot of areas that men deal with a lot of the time. So how did you get into that field?
Well, I'm board certified internal medicine, and I'm a general practicing physician for many years. I actually opened my private practice in 2005. And over that time period, in the first 5 years of being a GP, I saw a lot of men coming to see me, and we had a really special bond, men to men. And then a lot of men and more men were coming to me either on testosterone, and I started to become involved with diagnosing low testosterone, realizing that it's really not a subspecialty exclusively of endocrinology or urology. Indeed, urology experts are surgical doctors, right?
Mm-hmm.
And endocrinologists are experts mainly in diabetes and thyroid. They certainly can understand andrology and replacing testosterone and diagnosing it, there's no question. But if you really look into the details and management and diagnosis of men on testosterone, it's very complicated.
Sure.
It's a sub-discipline of internal medicine, and it affects red blood cells, cholesterol, the left ventricle, the prostate, hair, mammary glands, acne, and so on and so forth, mood.
Right. Sure.
Right. So I took this on 10 years ago and realized that it really integrated very well into a general medical practitioner's practice during the day. And now I'm happy to say that all I do exclusively is take care of men on testosterone to manage them very specifically, because primary care doctors, they really are uncomfortable managing men on testosterone. Not all, but it's very complicated from the polycythemia, the red blood cells. Again, there is a risk on this from the Fed several years ago that testosterone can cause heart attack, stroke, and death.
Right.
And with that, doctors, primary care doctors, internists, family medical doctors, and so on and so forth, APRNs and mid-level practitioners now, they're just not comfortable, and they don't have the time to really focus on managing men on androgen. And again, I want to be humble, and I don't want to be disparaging to these physicians. It's not that they're not smart enough, but
Sure.
it's a full-time specialty.
Right. Right. And I mean, that's very true. And I think it is hard for people outside of the field to understand that, because just the amount of information, I mean, just to be a general practitioner, the amount of information is unbelievable. And then you go into different specialties, and again, it's just more and more information. And, I have a friend who's a cardiac physiologist, and, his knowledge in that area is going to be far beyond the general practitioner, because he spent 5 years just studying that one thing. And so when you're talking about, testosterone replacement therapy, of course, somebody like you who's dedicated to it, for years and years now yourself, compared to a general practitioner who's probably not testing everything that they need to test, there's a huge difference there.
You just can't, again, it's the subspecialties of medicine, internal medicine. I mean, general internal medicine, there's 9, if not 12 subspecialties now, because they're growing.
Mm-hmm.
Every couple of years they add another. Cardiology, there's 7 cardiologists, right? I mean, there's electrophysiology, there's interventional cardiology, there's general cardiology, there's congestive heart failure only now. So, I mean, imagine me as a primary care doctor. So, but if you look for androgens and how they affect men, it's a classic subspecialty, because it affects the heart, of course, the kidney, it affects the liver, it's going to affect the red blood cells, the man's brain, his hair. It's going to affect a man's skin. And can you imagine? So what better doctor is there, I figured, that to coordinate this and to watch it carefully than an internist?
Sure. Sure. And, a lot of the people you work with are people with an athletic background, but you also, you walk the walk. And so I know you've competed in powerlifting, correct?
Yeah, I guess do you ever retire from it, or does the numbers change?
Right,
yeah,
right.
At 47, I'm 54 in 2 weeks. And at 47 in competition, I benched 505 pounds.
Jeez, that's crazy, man. Yeah, I was going to ask what some of your best lifts were, and
That
that's
was
pretty
at the weight
impressive.
class, at 198-pound weight class, 90 kilograms is my body weight. And I
Wow.
did use a bench press shirt. I'm not going
Hmm.
to, try to say I did it raw. I
Right.
did it with a bench press shirt on. So
Yeah, still very impressive. So one of the quotes I really liked, I heard you say was you were talking with a cardiologist, and you were talking about anti-aging and how anti-aging is kind of blown up now. And you said, anti-aging, how about not having a heart attack? That's your anti-aging. And yeah, I thought that was hilarious, but it's also very true. Is people, that is kind of a, I guess, specialty people are trying to market nowadays. But what are your thoughts on that? Can you expand on that a little bit more? What you meant with
yeah,
that quote?
thank you so much. Wow. Here you are. You're obviously a doctor. You're a dentist, correct? You're a
Correct. Yep.
general dentist. So you're educated, the medical system. So anti-aging means you want to live a long life. If you want to live, which you want to live a good quality life also. So if you want to live a great long life, you need to understand what's going to limit you from having a long life. And if you look for the number one cause of death in America, it's coronary artery disease, right?
Sure.
So my approach to anti-aging is don't have a heart attack first.
Right.
So the way I approach it is, and if you're taking agents that have a risk warning on them medically for causing a heart attack, stroke, or death, I don't see how anti-aging clinics, which are essentially working on hormones from testosterone and growth hormone, which I don't
Hmm.
prescribe, and we could talk about that in a minute. I don't see how there's no doubt. I'm an evidence-based doctor. I use evidence-based medicine like you do too. And that's how medical physicians should always start with evidence-based guidelines. That's when you communicate to your patients, you want to always work with them and say, this is what the standard of care is. And then you tailor it to them based on that's why we have the ability to do it, right? We're physicians based on their allergies, based on their other medicines, their other medical issues. I mean, this takes time. I teach at University of Connecticut School of Medicine as a primary care teacher. I always will because I love that.
Yeah.
I have a very small component left in my practice of primary care, including women. And I've had people up to 106 years old,
Wow.
107 actually.
Oh,
And
that's awesome.
so when you really understand the basis of how people can live a quantity of life, my most important piece, and I think everyone's going to agree, is quality of life is number one.
Hmm.
But if you're talking about anti-aging, there's no data to support that testosterone is going to lead to a longer life. It's embarrassing.
Sure.
Growth
Yeah.
hormone, this is embarrassing. This is straight
Yeah.
embarrassing. It's snake oil. And again, I work for my patients. I don't work for, I don't, I'm not contracted, but only with my patients. So, and I don't need to be the richest guy in the world. So
Right.
I don't sell pharmaceutical agents or supplements. I sell my advice and I'm a physician. So it's a service. So when it comes down to anti-aging, I can get very aggressive and it's the end of a long day. So I'm kind of, the fight taken out of me today.
Yeah.
We already had some interview. Things are going, pretty crazy. So anti-aging doctor, tell me, how do I anti-age? Well, let's work on your cardiac risk factors, blood pressure, cholesterol, diabetes. Let's try to employ a good diet and exercise regimen. Let's try to screen for disease that we know if we screen for heart disease or colon cancer, right? Lung cancer, let's not.
Right.
If we do these things, you're guaranteed that's anti-aging. So I'm
Right.
really an anti-aging doctor. But
Okay. See it.
I don't sell growth hormone, and I am an expert in testosterone replacement. Yes, thank you. But I do that for quality of life. And of course, I try to block the adverse side effects of testosterone, which the jury's not fully back in yet,
Yeah.
that there may be risks for some men. This is the truth. If 10 men take testosterone, of course, we hope they need it. They're not using
Hmm.
steroids.
Right.
If 10 men take testosterone and they're diagnosed properly and they're on a management regimen and they're being managed very well, like I do, which takes time, and they're by a physician that really knows how to manage them, and this takes decades and years, obviously, to understand. clinical experience. So in the end, if we look at those men and they're on testosterone, they're going to see a variability in the response as far as how it affects the man's LDL, HDL, blood pressure. Mm-hmm. Am I right or wrong?
Right? Sure, very right. Yeah.
So some men will take testosterone, even a small amount of testosterone, physiologic TRT. And I've found over years that their HDL is going to go down a little bit in most men, but it may not be clinically significant. Other men, it will go down significantly. And if that's a man that has other coronary artery disease risk factors based on the Framingham data, blood pressure, cholesterol, family history, you're in trouble. So that's what the feds discovered, and it was very crude. And since that period of 2015, when they put that increased box warning on testosterone products, heart attack, stroke, and death, since that time, it's been rebuked from the data from the 2013 JAMA article, the 2014 PLOS article. These are these major, right?
Right.
They did it based on only 2 articles. There's some politicization. It was politicized to some degree, and I'm not going to get into that. But the Fed was certainly concerned that based on these 2 trials, you looked like you had upwards of 30% of men dying within 1 year. Right. And they weren't dying from cancer of the colon. It was heart attack, stroke, and death. Right. So I've looked into it deeper, and I've interviewed board certified cardiologists on my website, on my YouTube, Metabolic Doc YouTube, where I'm asking an expert doctor, tell us about this data. And we reviewed the data, and it's inconclusive, but it doesn't mean that it's not true. It doesn't mean that all men are created equal in terms of disease, because they're not. People have different genetics. Sure. So we know, right? I mean, this is basic. This is nothing new. Right. If you give 10 men testosterone, some men will be at risk for producing plaque and growing their left ventricle and leading to early diastolic dysfunction and cardiac disease and coronary artery disease. I see it. Sure. So what I do is I individually diagnose and provide protection for each. Some men get statins, some men don't. We have new drugs called PCSK9 drugs, which I'm getting involved with. These are miracle drugs. Technology's advanced. These are monoclonal antibodies, right? These are incredible. They're expensive, and you have to get through the insurance company, but I work the best I can, and we have success most times. And then we have ACE inhibitors, we have beta blockers, we have diuretics, we have metformin, we have, so I use these medicines working with primary care doctors and endocrinology, cardiology, urology. I watch PSAs closely. Some men, if a man has prostate cancer, I can tell you this, I've dealt with this for over 10 years now. If a man has prostate cancer, when you start testosterone, most likely you're going to see that grow.
Right. And now it seems to be that testosterone, at least, I mean, from what I've seen, is kind of inconclusive about it causing prostate cancer.
It does not cause prostate cancer. Right. So let me be conclusive. Okay. When I can be conclusive, I will. I don't want to cut you off, but if I can be conclusive, I'll tell you there's arguments over. Testosterone androgens have been proven they don't cause prostate cancer.
But if you've got it, they can exacerbate it, correct?
If you have cells of malignant cells in that stroma, in that prostate tissue that have been converted to a malignant cell, and you introduce androgen, not to mention physiologic or super physiologic with these biologic, these drugs, these esters, or you could cause that growth of it to speed up. And funny enough, some of the UK data showed that it actually brings out prostate cancer earlier when it's in the prostate, because you detect it and then you save the guy's life.
Sure. Well, I think that's one of the issues. The reverse of that is one of the issues with drugs like finasteride, right? Is that sometimes they find higher grade prostate cancer, and they suspect that might be because they're not detecting it earlier.
So 2 studies. So you're pimping me out here, which is good, right? I'm the metabolic doc. I better know this stuff. So that was based on 1 initial study. Here was the basics. And again, I'm not prepped up for this. I mean, the study was maybe 10 years ago now. And it was a study, not men on pharmaceutical they're not on testosterone.
Mm-hmm.
So remember, you got to put your brain cap on this for this. This was a data that showed men we use finasteride for hair, for propecia loss, DHD, and we use it for BPH.
Right.
So so this is men that they were watching men not on physiologic, not on testosterone replacement. They gave them for BPH, I assume, finasteride, and I don't know the dose, 2.5 milligrams or 5, pretty good dose. I mean, you got to worry. The guy had finasteride syndrome, right? Later, and he had low T, and his sex drive wasn't good. But this is another issue. So they looked at data, and it looked like overall incidence of prostate cancer was reduced.
Mm-hmm.
But the problem was the men that had prostate cancer, the grade of the malignancy was worse potentially.
Right.
Now, fast forward to another study several years later where they used dutasteride.
Mm-hmm. They
used a DHT 1 and 2 blocker, and they found that the data did not support that.
Interesting. Okay.
So again, I'm a real bro scientist, from the underground. So everyone's using anti-aging clinics they give androgens, not to mention other drugs, and they start playing a game with using blocking agents. Well, if you're going to have androgen, you're going to aromatize. This is why you have me on the show, right? For this cool stuff.
Sure. Yeah.
You can have any other good endocrinology doctor on, and he knows what I know, but he doesn't know this, and I can go forward. So he doesn't know, the bro science of so if you take androgen, these doctors called anti-aging doctors, and again, I'm trying not to be too aggressive, but I just don't agree with anti-aging. It's stupid. Anti-aging, dumb. It's unethical because you're selling medicines against any evidence-based guidelines. So, okay, people like it though. That's what they want. So that's another issue. So you take testosterone and then some people will aromatize. So block it with breast cancer drugs. There's 2 or 3 drugs that will do that.
Mm-hmm.
Okay. The next stage is, your testicles are going to shrink. So take a fertility medicine that we use for, men and women, human chorionic gonadotropin, take that at the same time.
Mm-hmm.
We're not done. We're not done yet. Depending on
what. Got to save the hair, right?
I mean, so there you go. So throw in the finasteride or dutasteride, throw that into the mix. I'm not done yet. Then we throw in selective estrogen receptor modulators, which I guess can be part of the whole reproductive, and then we're going to run that at the same time. And I am not kidding. I mean, so these guys walk out here, the average 45 to 60 something year old bear walks out of this clinic, decent guy. He may or may not have had low testosterone. He walks out on testosterone and 5 other drugs. He doesn't know which end is up. He's paying for them at a pharmacy that is associated with this clinic. I'm just telling you the truth. This is how a lot of it works. And they pay this a la carte menu, and they end up coming to me. I mean, this is where I'm the New York guy, and I guess I have an attitude. I'm not here to get fans.
Yeah.
I'm here as a physician to do the right thing and care for people as an expert. And if I don't know something, I reach out to other doctors, and I basically run the team. I'm the man. I become the manager of these men.
Yeah.
And when you're on all these medicines, there's problems.
Sure.
Big problems.
Yeah. I mean, I've seen it even, myself. I had a patient, I think it was just last week, and he was on warfarin. So we wanted to get his INR before doing a procedure. And so I called his cardiologist because he sounded a little, unsure of things. So I called the cardiologist, and they had listed his medications to me because, obviously I got his approval to do that. But he was on testosterone. He was on pretty much everything you just listed. He was on testosterone, HCG. I mean, and he looked like a competitive bodybuilder. We didn't talk about it too much. He said he lifted a lot, was all he really said. But yeah, huge drug cocktail. And, I didn't go too much into it. I kind of just needed that one main value there.
It's just ridiculous. I mean, I can't come up. I'm trying to be, eloquently speaking here, but it's just the only word that comes up is just unethical and ridiculous.
Yeah.
It's been going on. I mean, am I wrong? Am I right? It's not. Hold on. I use these medicines on a very focused level because you can use these. None of these are controlled. Testosterone is a controlled drug, but the other medicines, apart from HCG, which in some states is kind of a quasi-controlled drug, And I'm not, they also get growth hormone and growth hormone releasing peptides, Sermorelin. I mean, this is just,
Yeah.
again, if you want, so patients that want to go to those places typically don't see eye to eye with me.
Mm.
People that want unregulated steroids and that want cowboy stuff, they're not going to come to me. Men that are on testosterone that want a great quality of life and they respect a physician that's more like their GP,
Mm-hmm.
my wheelhouse. Those are my clients.
Right. And that's one of the reasons I want to have you on is because, everybody's going to have bias, of course, but you seem to really step back. And even though your main business comes from testosterone replacement therapy, you're not out there telling everybody's got to get on. This is the best thing, So you seem to take a very objective view. And that's one of the things I want to talk about is for men. Like I know my dad, he's 60 years old now, but his last testosterone level was around 500. So when you see a 60-year-old man with completely, at least to me, 500 at that age is good. Do you still see a need to look into that for testosterone replacement therapy, or do you say, hey, if you're not symptomatic?
Let's make it very simple. I have two hats. I have a diagnosis hat and I have a management hat, right? It's got to start off with diagnosis.
Mm-hmm.
So when you diagnose a man with low testosterone, he comes in, you get labs, and then you do a history and a physical exam, correct?
Yep.
And you ask him it's called the chief complaint. In the history of present illness, what's up, buddy? What's going on? How's your sex drive? How's your energy? It doesn't mean every man that has higher normal testosterone. It becomes complicated. So then you look at the level, and then in the endocrine society, I'm much more in their wheelhouse than I am anyone else's wheelhouse. I mean, these are endocrine. So the guideline for testosterone replacement from the gut that tells you the common sense and the ethical is you do a history, physical, you hear the man's complaint. It's going to have something to do with sex. If a guy has testosterone level from 250 to 300 to 700 or 1,000, and he has a sex drive, and he goes, whew, sex drive's great. Yeah. He's not getting testosterone from me. But on the flip side, if you have a man that has levels that are, say, around 250, 300, or in the mid 300s, and he has a poor sex drive, you have to reach into this and you have to figure out, and then you look at total versus free, right? So now it gets very complicated.
Right.
So your dad could have 500 normal, but this is the bro science. Again, not all the anti-aging stuff is not all useless. In part, that learned a lot. So endocrinology doctors, if you're diagnosing testosterone and you know what you're doing at least one sample in the morning. It's going to be a total and a free. It's going to be a liquid chromatography mass spectroscopy run by a dilution method. Did I just say all that? That was a lot. But I'm just showing off, but it's true. So you better do the right test, and you better just not do a total, because your dad, when men get older, that's not old. He better not be old, because I'm right behind him. So, and I'm trying to stay in great shape, trying to enjoy mountain biking and a great quality. Everything, my friend, is quality of life.
Sure. Yep.
You want to have the best quality of life for the longest life. Anti-aging, you better go see a good internist. Stay away from anti-aging doctors, so they're just going to sell you garbage. I may get punched for this, but I may get smashed from this, but that's just, I'm in bed. I'm in the camp of real physicians that are overworked, that are super great people, men and women. They're working in this country and other countries, and they're trying to help people, and they're trying to, there's a round peg in a square hole a lot of times because of the time, the money problems, the payment problems. Right. So back to the testosterone, you have to understand it's not just a number. If you, but do you have to be doc? They all say to me I've seen thousands of patients. Doc, right. The number low has to be 249. Doc, I'm 252.
Right.
Go away, sir. So,
right.
So the Endocrine Society has said you have to look at labs. You have to do the right labs, which is a total and a free, and the dilution method. It has to be that liquid chromatography. That means dilution method. It has to be reproducible. You really should do it once or twice. You don't need to, but you should. If a man realizes that the seriousness of going on this medicine is permanent and could really have side effects, including cardiac and prostate, right? Sure. Hair loss, gynecomastia, mood issues. I mean, not everyone on testosterone has great sex, by the way. Right. We're complicated creatures, pal. So when you look at that and you see that it's a clinical diagnosis, we use labs to support it. Obviously, if a man is 700 and his free is normal, and he's 28 or 38 or 48 and 58, he's not getting testosterone from me, but he's not coming to see me.
Right.
Most guys who come to see me are already on testosterone. The diagnosis has been made. They're on long enough. Hopefully it was a proper diagnosis. But again, sometimes it might have been a weak diagnosis. But regardless, they're on testosterone now for a year, 5 years, 10 years, and their red blood cells are elevated, right? This is complicated. Their HDL is low. Maybe they had a heart attack or a stent placed. Maybe their prostate's enlarged. And now they come to me, which I'm very humble, and because this is my day job. And I pick up the management, and I work again with other physicians, including primary care, urology, endocrinology, cardiology, hopefully not nephrology, because hopefully the kidneys are not damaged.
Right.
And that's more the steroid level guys, they're doing excessive physiologic doses and they're getting really beat horrible. They're getting really hurt really bad. But testosterone dose dependently, the more you take, it's like booze. You do a little bit, probably okay.
Right.
You do a gallon of vodka, you're going to pay the piper.
Right. Right. And so one of the drugs you mentioned was statins. So, I see tons of controversy over statins. Some people think it's a miracle drug and it's the best thing that we've had. It's one of the most prescribed drugs out there. But then there are other people who talk about the actual absolute benefit from it is very minimal. And the number of lives actually saved, the mortality risk really doesn't change that much. So what are your thoughts on statins?
Well, being that I'm getting into polyclonal, the PCSK9 drugs more, you know what those are, right?
Yeah, so, only a little bit, and I'm not too informed on them.
Yeah, so I'm moving into targeting on those because they've been out for years now, and I feel I don't like to be a bleeding edge guy. I want to be cutting edge, but not bleeding. So I'm an expert in internal medicine, obviously, and blood pressure, cholesterol, and diabetes. That's my stuff. Game on. Metabolic doc, metabolic syndrome.
All right.
So let's talk about statins. Statins are miracle drugs for many reasons. Number one, the data shows in a primary care fashion, they reduce heart attacks. No one could argue it. They reduce it. No one could argue it. The first event of a heart attack. And then if you've had a heart attack, they're going to reduce the secondary and tertiary endpoints with having another heart attack. Okay.
And do we have percentages on those? How much?
Yeah. I'm not a cardiologist, but there's so much data for this, sir, that we could have a whole other show reviewing.
Sure.
How about 150 journal articles? Sure. No one's arguing that. Here's what, and again, people would love to argue that. That's not arguable. It's not true. It is true. Statins work on lowering LDL. They also have other properties that are endothelial stabilizing. And you know what I'm talking about, right? Yep. You're a doctor, so I can talk to you like this. And for the audience, they're endothelial stabilizing. They have other pleiotropic qualities, that's called. And outside of lipid lowering, people on statins just have less heart attacks. And I'm not sure about the living longer. I think there is mortality benefit on that, but I'd have to get back to you on that.
From what I've seen, they kind of push it as they looked at the relative risk, but the absolute risk, if I remember correctly, the percentage was pretty low in that, at least one study I remember. Fairly large study.
So they do protect against heart attacks. No one's going to, first heart attack and second heart attack. No one's going to argue it. They do. They do. So, and that, sir, doctor, that right there makes it a miracle drug. And the next reason is they're accessible. The new drugs, the problem with those are they work and the data's looking better and better, but we're not going to get into those PCSK9 drugs right now. That's another show. That'll be another show. The problem with those drugs, doctor, they're not accessible. $14,000 a year. You gotta browbeat the insurance company, and it's not easy. I'm a primary care doctor, right? That's my job. That's my like ex bread and butter. Like I'm an internist. I'm in network with insurance companies, including Medicare. And I'm not putting them down. Things are tough, man. Things are tough all over. This is expensive. Medicine's expensive. The services are expensive. Insurance companies, people have to foot the bill. Who's going to pay for it? Statins are dirt cheap, sir.
Right.
Now, side effects. Let's go into it. Statin-induced myalgias. I was talking to the rep today about these Praluent. It's one of the two big drugs, Repatha and Praluent. Got to pronounce that properly. So these are two incredible drugs, and the side effect profile on statins, I'm with you.
Yeah.
It could be bad, man. A lot of people, the data for that in primary care is 10%, up to 10% of patients can have statin-induced myalgias. I have them.
Yeah.
And that stinks. But I continue to take my Crestor, and I take a pretty good dose every day,
Yeah.
despite kind of waddling around and going, man, I feel kind of achy. And because I'm a hypochondriac, I don't want to have a heart attack.
Now, did you take them because you saw your lipid levels were negatively affected, or was this a preemptive thing?
When I was 39 years, I'm 54 in 2 weeks.
Mm-hmm.
When I was 39 years old, I had the opportunity to have a CT angiogram done with a calcium score.
Yep.
And the arteries looked pretty good, although there was a little area they weren't so sure about. I was like, "What? Are you guys kidding?"
Yeah.
But I had a calcium score of 15. So at 39, I technically had the beginning of heart disease.
Yeah. Wow. Okay.
No one's going to argue that. No one's going to argue. The calcium in my LAD, it didn't come. There's a lot of people that have zero. So all I do now, every man that comes in, unless he's 25 or super great genetics and he has no risk factors at all and he's below the age of 40, every man I do a coronary artery calcium score for. You should see the data, what I'm developing. This has been about 3 or 4 years now.
Yeah. Okay. Nice. So as far as the lipid panel, do you tend to stick with a traditional one, or do you go into the, they do these advanced cardiac IQ ones now?
So great question. So you got to, the data shows us, different things, but the basic data still goes on the Framingham basic total LDL, HDL ratios and triglycerides. It's still pretty solid, man.
Yeah.
And then if you look for that, because coronary artery disease is multifactorial. It's inflammatory. It's part cholesterol. Now the diet's changing. Carbs are poison and fats are okay. I mean, it's getting crazy right now.
Yeah, yeah.
So to answer that, less is more. I look at guys like Paul Thompson. He's a lipidologist, cardiologist at Harvard Hospital. He's one of the top lipidologists, and he takes care of athletes. He's more of a marathon runner. I'm more of the anaerobic guy, but I'm changing because I'm a mountain biker now, so I'm kind of both.
Yeah.
But he will. The data shows that less is more. I mean, people that have lower LDLs just endogenously, from whatever their genetics and their lifestyle and so on and so forth, your outcomes are better for myocardial infarction and heart failure. I mean, just no one could argue that number. So, but it's not just that number, though. I do agree with that. It's a multifactorial piece, and you have to put the LDL in perspective for people. That's why for men, I pretty much, in this fashion, only take care of men for my metabolic division. So, and they're not all on testosterone, but executive men come in and I'm an expert. That's one of my divisions where I manage blood pressure, cholesterol, and sugar before they have a heart attack. And that's a growing division of mine.
Right. And yeah, the lipid stuff really interests me because, now there is, as you're well aware, more data talking about the small LDL, small dense LDL, and it seems that statins somewhat preferentially decrease those from what I've seen. I've measured those a few times myself, and it's interesting to see the data. I don't know if, like you said, if it's really changing anything for me as far as what I'm going to do. But it is interesting to see. I'm looking to see more research as that comes out.
Well, I can tell you this, though. So I want to fully answer your question. I do appreciate it. I do use advanced lipid panels. Yeah. And in the advanced lipid panel for the audience, it's basically beyond, LDL and HDL and total cholesterol, triglyceride. And what does it look at? And it depends on what panel, but it's going to be APO lipoprotein D, LP little a, and it's going to be, depending on what you use, plaque 2, which is potentially now we're getting into like esoteric, but LP, let me tell you, LP, and it's subfractions of LDL and HDL qualities. And I can tell you this, LP, those small dense LDL particles, the data, as you know, and having poor quality of HDL, then you start comparing it to the quantitative numbers in the standard lipid panel, and then you see what's called residual disease. So you have men and women, but this is mainly men. They have early heart attacks anyway. They end up in the cath lab. They get a stent placed, and they say, "What are you talking about, Mike? I was on a little statin. My blood pressure wasn't bad. My cholesterol, my sugars are like, my A1C is like, I don't know, like 6.1, 6.2. Maybe the A1C is actually, less than 5.7. and he doesn't really have any risk factors. And
Right.
then you do, this is when I was a resident with Paul Thompson in 2002 to 2005 at Hartford Hospital, University of Connecticut. He found, and other doctors, I don't want to say that it was just him, we started looking at these details in LP little a. This is a genetic subfraction of these particles that are atherogenic, right?
Yep.
So I look, and so you see, and I'm not board certified in lipidology. I'm board certified in internal medicine, but I love lipidology. It seems like you do too.
I do.
And
Yep.
it's cool to integrate that, because I have my patients, they pay a small retainer, and they're able to have me as an exclusive doctor. So I could spend, the first visit goes 90 minutes.
Yeah.
So I get to spend, and then they're basically paying for an exclusive practice, and I obviously want to show that off. And we're expanding in Florida, and I'm going to hire doctors. I got to try to find someone as crazy as me. But it's fun. But what man doesn't want to really, really have access to a good doctor? There's tons of great doctors, but the problem is they have no accessibility, right?
Right.
So it's fun to put together all these cardiac risk factors independently for a man and tailor everything. And, look, the truth is people try to do diet and exercise, but we all can't, because, our brains tell us to go for sugar and things. And it's, so it's better living through chemistry. We shouldn't dump medicines on people. But I mean, look how I'm living, and I try to show off my activity levels with, pretty incredible things I do. And I'm on most of these medicines, but little baby doses.
Right. Right. Yeah, I remember you had a video at one point showing everything you were taking, and like you said, it's relatively small doses of these things. So
it's just, and I change that, but I'm always on a statin until I start the other medicine, because I want my LDL to be way less than 100.
yeah.
And my blood pressure can be a little, because I'm a nervous, Nelly,
Yeah.
and I'm not fat, but I'm a little puffy, and I try to keep down my carbs now.
Yeah.
So I take a little bit of metformin, and metformin is a secret drug. I tell you, metformin is an absolute anti-aging drug. I am an anti-aging doctor. Metformin.
Well, yeah, talk about that, because we talked about HbA1c a little bit, and metformin. The safety profile on metformin is pretty good, and seems to be a ton of benefits for it. So I don't think, a lot of people are scared of statins. I don't think too many people are really scared of metformin, but
You're
maybe
right.
I'm wrong there.
You're right. So if you look for the data for, apart from frank diabetic patients that have an hemoglobin A1c of equal to or greater than 6.4, and fasting glucose panels, metabolic panels indicating greater than or equal to 126, right? I mean, then you're a type 2 diabetic. This is not type 1 diabetic. This is American diabetics. I believe it's 90% of American diabetics are type 2. We get older, our waists get bigger. The insulin that we produce is becoming not effective. It's called impaired fasting glucose. You and I both know the receptors, tyrosine kinase, that we know the fit of them. We know that it's very, very complicated. And we know how do you combat that is lose weight, cut the carbs down. Well, I had Haagen-Dazs last night. I don't want to do a pump out for Haagen-Dazs, but I try to live carb free. It's hard, man. Ketogenic, forget that. So I realized years ago, as I was getting older, I have a little wine on most nights. I have one or two. I love a little red wine, and that's sugar and ethanol. And then with my piece of pizza that I may have once in a while, my A1Cs, I was getting up to 5, 6. I was like, what?
Yeah.
I'm the metabolic doc. I'm becoming pre-diabetic.
Yeah.
I got to shut this up. So I started looking into years ago on the data, apart from diabetes, metformin. Metformin is, in my opinion, and it's under study right now, and there's some politics on it, and I don't want to talk about the politics. It's cheap. It's readily accessible. It's been out there for decades. It is an endothelial protective medicine, bar none, bar none.
Yeah.
And if you just look for the A1C data, if you're living at 5, 6 or 5, now if you're pre-diabetic and you try your diet, it doesn't work, and the A1C is going up and up, and you're climbing up. There was a big study in 2001 or 2002 when I was a resident that showed that metformin protected people from becoming type 2 diabetics. So it's ethical And it would be poor medicine not to do something for someone if you see they're launching off to be a type 2 diabetic over time. You tell them about diet and exercise, but people can't always live like this, and you should not hurt them. I'm very progressive. You should not hurt people. And, left to their own devices, you should help them. If it's accessible and it's feasible and it's safe. So metformin in multiple trials now lowers A1C, and depending on the person and the dose, and it lowers A1C. My A1C now never goes over 5 or 5.1.
Nice.
The glycosylation damage. Now, again, I'm not an expert in metformin. I'm an expert internist. I'm an expert in pre-diabetes, diabetes, as far as I'm not an endocrinologist, hypertension. I'm an expert in putting all these pieces together and diagnosing them and treating them. This medicine, I'm putting a lot of my patients they have to be my patients. They have to come under my microscope. I'm putting a lot of men on early metformin because their sugars are elevating. They're pre-diabetic now. Let me tell you something. They feel great. I see an improvement in erectile dysfunction, unbelievable, because it's got to improve the endothelial tissue and lead to increased nitric oxide.
Right.
This is a cool show right now because that's a study that I'm giving away some secrets right now. Someone should do that study.
Yeah.
It's unbelievable, and it's very well tolerated. And it doesn't give you the free ticket to just eat whatever you want. But you know what? Life is hard enough.
I'm glad you said that, because in that perspective, and I think that's the difference between, just a bro side versus a medical side, and you coming in between there, is because there's times, like some of my patients too, where somebody says, well, if they did this, and this, well, then maybe they wouldn't need that procedure. And it's like, well, that might be true, but they have a 30-year history of not doing any of those things. And I'm not going to, I'll coach them to try to, pick up those habits, just like you, try to improve your diet, exercise, things like that. But if they have 30 years of smoking and being sedentary, we're not just going to throw them out the door and say, well, sorry, just fix this with diet and exercise. We want them to do that, but you have to, find a middle ground there.
When ethical, whenever people ask me about ethical questions and testosterone and steroids, the answer, I don't have to think about these answers. It's very straightforward. Do we know what's best for the patient? And if we do, that's the answer. If we don't, the answer is we don't know, so we better be careful.
Right.
I mean,
Right.
When it comes to metformin and statins and blood pressure medicines, they're all generic. So accessibility, at least from that standpoint, is much better than it was. Now the problem is, do you have caregivers that are accessible, that have, look, I don't want to be a jerk, but that have the clinical know-how. Like the rate limiting step becomes you and I, the caregiver, the expert physician and caregiver, and that's a problem. And then you have compliance. But, men come to me and they pay me money and they come to me as a man to a man on testosterone and sex and all these things, and they want to live and have no heart attacks. They are 100, pretty close to 100% compliant. You know why? They're paying for it.
Yeah. Yeah.
So there's no better motivator than money, because these guys are saying, I want to come see the doc. I got to pay a little bit of extra money. Is it going to be worth it for me? Well, they make me work. So they read this, and I will go on. I mean, I work, how much do I work? I sleep 5 or 6 hours a night, therefore I'm working. So, but it's not work. It's not work. It's fun. It's fun. It's exciting. You're helping healing. You're working your dream. You went to med school, you and I, to heal people, right?
Yeah, and I think we can get into a whole tangent about, how you were talking about the incentive with the money, and how I think sometimes I'll have a patient where 100% of something is covered by insurance, and it seems like they're just less compliant because they didn't have to pay for it, but we don't have to go down the whole insurance rabbit hole.
We don't have to go into that, but at the end, obviously, we live in a pretty good country, and it's a lot better than some other places, but we can always work on things.
Yeah. All right. Well, I don't want to keep it too late. The last question I have for you is, for the people who have been doing this for a long time, there are a lot of mistakes made along the way. So what are some of the mistakes you see? And coming from this interview, what's the next actionable step you think men can take?
That's great. You're talking about men on testosterone, you mean?
Well, let's just say men between, let's say, 20 to 50, just trying to be as healthy as possible. Maybe testosterone, maybe not, but just listening to this information.
Easy.
The next.
That's an easy answer.
Okay.
You have to, obviously there's behavior. Don't smoke, exercise regularly. If you have any disease states, from congenital family, you have to go see an excellent caregiver, and it's a primary care. It's going to be, and I'm sorry that they're not accessible, and there's less and less out there, but they're out there. Educate yourself. The tenets of health are quite basic, and part of it is going to be you need to have a medical manager, 100%, because there's genetics and there's other, and unless you're this perfect person, which where's this person?
Right.
That is not drinking excessively, not smoking, not eating excessively, exercising perfectly. He has no stress in his life. It's a joke. So you need to have a caregiver. It doesn't have to be obviously me. That's why all my stuff is for free. All my videos and all my writing is for free. I'll never put a premium on that. Never. It's always for free to disseminate and to work with other caregivers. And so that's number one, is have a team, have a manager, a medical manager. It has to be an internal medicine, primary care, family medical. It has to be. It has to be. If you don't have it, you could have a nurse practitioner or an APRN. They can be very, very good. I'm not going to get into the pissing match about that, but I mean,
Yeah.
You went to med school. I went to med school. The experience level is, so we'll leave it at that. And the next thing is, so the mistakes being made are not diagnosing things early and following adequate care. And of course, the obviously mistake is going to be compliance. So are people compliant with eating and drinking and smoking? And this is like people who really want to help. Men come to me who are really great, and they've already done everything else. They have their careers. They try to be humble. They're successful. And then the last stage is, they're missing that caregiver, but they can't get me in a walk-in clinic. And I don't want to put the walk-in clinic down. The walk-in clinic is a different animal. God bless those people.
Right.
So, it's a different animal. I mean, so they're seeing 40 people per day sometimes, and I see 6 people per day, but these men pay me a premium to slow me down. It's a VIP place. I'm a VIP doctor for men. So, and this has been going 15 years, and it's all I do. So, and I love it. So they make that mistake. They're not having a good medical manager. And, is that the answer? Is that the question?
No, that's great. That's great. I think that's just something people can take from this. So you are the Metabolic Doc, and you have a YouTube channel. Is it just Metabolic Doc?
No, so I have two YouTube channels, and that you can access them at metabolicdoc.com.
Metabolicdoc.com. Okay, great.
Yeah, and there's Metabolic Doc is the general one. I do have the Anabolic Doc, which is I'm a doctor trying to educate the world on the dangers of steroids, but we'll leave it at that.
Okay. Well, we all appreciate you coming on here and the free information that you've been giving us.
Awesome. I do appreciate it. We'll do it again sometime.
For sure.
Have a part 2. Thank you so much for having me.
Hope you guys enjoyed that conversation with Dr. Thomas O'Connor. We're definitely going to have him back on the show. If you have topics you'd like to see covered, feel free to comment down below, like the video, subscribe to follow along for more interviews like this. And if you like the charity that we're going to be donating to, please feel free to make your own donation as well.